A warm good morning and Merry Christmas to all the healthcare industry leaders, CEOs, doctors, nurses, pharmacists, paramedics, quality and safety managers of the hospital, health policy makers, head of healthcare associations, and university professors. I am Srishti Prajapati, President of Forum for Pharmacy and Master of Ceremony for today's event. I'd like to start by extending a very warm welcome to all of you in today's Patient Safety Conference, Safecon 21, collaboratively organized by Karuna Hospital and Health at Home with the theme, Moving Beyond Blame to Developing Culture of Patient Safety. Patient safety is a core essence of healthcare service delivery and is fundamental to deliver health services which are effective, safe, and people-centered. The data on patient safety in Nepal is quite scarce, though we do come across a number of riots and violence against doctors and healthcare workers, accusing them of medical negligence. Patient safety is a multidimensional issue and has to be talked about more often. Today, we are here for a new beginning of Nepal's healthcare quality improvement. Initiating the program with a keynote session, I'd like to call upon the stage Dr. Prakash Thapalia. Dr. Prakash is a consultant at Everett Clinic and Provident Hospital, hematology and oncology at Mayo Clinic, internal medicine at Pennsylvania. He completed MBBS from Manipal Pokhara. Please.
Almost all big clinics and the hospitals have a quality and safety department. And what do? They work on quality, they work on accreditation of their staff, they work on risk management. If something happens to the patient, what are the financial risks, what are the legal risks, all those things are taken care of by the risk management department. There is a data collection department, there is the infection control department, environmental or sanitary control department. There are actually personnel who do surveys and look at the outcomes of the implementation of the safety protocols. And obviously, we all know about the quality improvement.
मान्छे नामको निमित्त बाँच्ने कि पेटको निमित्त बाँच्ने मैले त्यही भनेको पेटको निमित्त बाँच्ने मान्छे र मनको निमित्त बाँच्ने मान्छेको फरक यति छ त्यसो भए भगवान कोइरालालाई चाह्यो भने संसार कुन चाहिँ रेस्टुरेन्टमा कहाँ के he could have lived like a king in any part in the whole world, but he is happy. It is his own too. The institution, they become like an institution of this country. And you guys can also become an institution like the country. The पेट पालक निमित्त मात्रै पेशा गर्ने हो भने जानुस् अमेरिका मन भर्नको निमित्त पर्ने हो भने बन्नुहोस् विशाल ढकाल बन्नुहोस् डाक्टर पवन कोइराला Thank you very much.
Thank you so much, Karna Sakyashar, for sharing your story. It was really motivational for us. साँच्चै नै मानिसको शब्द बोली र सद्भावमा निकै शक्ति रहेको हुन्छ. Now I'd like to request everybody to please silence your mobile phones. Continuing, we have a gracious presence of Dr. Bhagwan Koirala, who is a cardiothoracic surgeon, professor, and social worker. He is the pioneer of open heart surgery in Nepal. Now, with all due respect, I'd like to call Professor Dr. Bhagwan Koirala to share your speech with us. Let's welcome him with a big round of applause.
साँच्चीकै गएको 20 वर्षमा नेपालमा हेल्थ सेक्टरमा राम्रै काम भएको छ विशेष गरी क्वान्टिटेटिभ चेन्जेसको हिसाबले संख्या अस्पतालहरू बन्ने क्रममा न्यू इनोभेटिभ फाइनान्सिङ मेकानिजमहरू ल्याउने बेलामा म आफैलाई याद छ मैले गङ्गालाल हस्पिटलको पहिलो वर्षमा बस्दाखेरि हाम्रै मञ्चबाट आफ्नै स्वास्थ्य मन्त्रीले चाहिँ यस्तो खाली अस्पताल किन चाहियो देशमा भनेर मलाई नै भनेको र हाम्रै अडियन्सलाई भनेको मलाई याद छ तर त्यो बेलामै हामीलाई थाहा थियो कि देशका जनता 2-2.5 करोड जनताको विभिन्न थरीकाको रोग हुन्छ प्रिभेन्सन जरुरी छ, तर उपचार पनि त्यतिकै जरुरी हुन्छ बिरामी पर्दा। र इकोनोमिक्सले हामीले के साबित गर्यौँ 10 वर्षको इभ्यालुएसनमा भन्यो, देशले धेरै डिसेन्ट्रलाइज्ड स्पेसलाइज केयर अफोर्ड गर्न नसके पनि एउटा दुईटा स्टेट अफ द आर्ट फाइनल डेस्टिनेसन्स फर इच टाइप अफ डिजिज चाहिँ उपचार हुने चाहिँ देशभित्र चाहिँदो रहेछ। त्यसको इकोनोमिक्स चाहिँ इभेन्चुअली वी गेन एट ए नेसनल लेभल रादर देन लुजिङ, किनभने अन्यथा हाम्रो सम्पत्ति देश विदेशमा धेरै जान्छ र गइराखेकै छ, विभिन्न क्षेत्रमा गएको छ। त्यसैले यो खाले कुरामा ध्यान दिनुपर्छ। तर गएको 20 वर्ष जतिमा म आफै प्रत्यक्ष विटनेस गरेको टाइममा वी हेभ लट अफ हस्पिटल्स, लट अफ गुड इन्स्टिट्युसन्स, लट अफ डाक्टर्स, र हाम्रो पैसा विदेशमा जान र नेपालीहरूलाई अलिक गुणस्तरीय स्वास्थ्य उपलब्ध गराउनलाई संरचनाहरू बने। तर अब नाउ इज द टाइम वेन वी टक अबाउट दिस, जबसम्म हामीले त्यो प्रदान गरेको सेवाको क्वालिटी, सेफ्टी र साइन्स सुनिश्चित गर्न सक्दैनौँ, हामी कहाँ इभेन्ट्सहरू भइरहन्छन्, हामी कहाँ घटनाक्रम भइरहन्छन्, विश्वसनीयता आउँदैन, एन्ड अफकोर्स पेसेन्टको सफरिङ कस्ट र चाहिँ ब्याड आउटकमले हामीहरूलाई हन्ट गर्छ र विश्वास नआएपछि यो भिसियस साइकल विल कन्टिन्यू। यस अर्थमा भन्ने हो भनेदेखि आई थिङ्क दिस इज अ पर्फेक्ट टाइम वेन वी स्टार्ट टकिङ अबाउट द क्वालिटी इम्प्रुभमेन्ट एन्ड पेसेन्ट सेफ्टी अफ केयर इन नेपाल। एरर्स एन्ड सिस्टम फेलियर्स आर प्रिटी ऱ्याम्पेन्ट। अब त्यो रिस्कहरू मिटिगेसनको एक्सन्सहरू आर भेरी लिमिटेड। लिसन, अहिले प्रकाश डाक्टर साहबको किनोट एड्रेसमा पनि ही ब्रट इन सम टपिक्स एन्ड उहाँले पनि भन्नुभयो नियर मिस, मर्बिडिटिज, यो कुराहरू भनेको चाहिँ हामीले ध्यानै दिइरहेको हुँदैनौँ। हामीले मरेपछि या ठुलो अङ्गभङ्ग भएपछि मात्रै त्यो कुरा उठ्छ, लफडा हुन्छ या हामीहरूलाई अलिकति इस्यु चाहिँ दिन्छ। तर त्योभन्दा ठुलो स्कोप, मेनी मोर टाइम्स वी हेभ नियर मिसेस। त्यो क्विक एक्सन नलिएको भए या देउताले नजोगाइदिएको भए मान्छे मर्थ्यो या अङ्गभङ्ग हुन्थ्यो। त्यो नियर मिसको बारेमा हामीकोमा कुरा गर्ने कल्चरै सुरु भएको छैन। बाई एन्ड लार्ज डिटेक्सन सिस्टम्सहरू पनि ठ्याक्क टाइममा राख्नु पऱ्यो। म त्यो बारेमा अलिकति बोल्छु। हाउ डु वी डु डबल ब्याकअप, ट्रिपल ब्याकअप इन प्रिभेन्टिङ फेलियर्स। अब वी डोन्ट हेभ अ रुटिन कल्चर। धेरै ठाउँमा इन्सिडेन्ट रिपोर्टिङको कुरा चाहिँ छ, but that's not in routine practice.
Now we are moving forward to another topic, ethics and knowledge regarding patient safety and role of professional counsels. Despite various patient safety guidelines and standards, less attention is paid to the ethical and legal aspects of this issue. Patient safety is closely related to the concept of human dignity, and all the patient safety measures taken must ensure the protection of humans' dignity. Strategic leadership and collaboration across the professional council is vital to ensure all the staff have the right skill, knowledge, values, and behaviors to ensure patient safety. To moderate the panel discussion on this topic, I would like to call upon the stage Dr. Saugat Paudel, who works as a clinical oncologist at National Academy of Medical Sciences, Beer Hospital. Also note that we have the question-answer session after panel discussion, so please write your questions in the A4 paper and pass it to the coordinators of hall.
Well, thank you, Srishti. So, good morning, everyone. I'd like to begin this question with Mohan sir here. So, Roshni ma'am, I'd like to come to you. In the first vignette here, like a wrong amputation has been done. So, the thing here is, of course, we talk about surgical checklist. We are talking about all the things on the surgical checklist. I mean, surgical checklist could have prevented this error. So, how do your nursing professional council react to this error?
Yes, thank you, Dr. Saugat. यो दुईटा सिनेरियोमा मैले फर्स्ट सिनेरियोमा अलिकति बढी हाइलाइट गर्न चाहे। यो फर्स्ट सिनेरियो जस्तै कन्डिसन नेपालमा धेरै घटनाहरू भइरहेको छ। To prevent such type of scenario, our main target is by proper implementation of the surgical safety checklist जुन हामी सबैलाई थाहा भएको। सर्जिकल सेफ्टी चेकलिस्टमा हाम्रो बिफोर सर्जरी हाम्रो के अरे प्री अपरेटिभ चेकलिस्ट, अर्को चाहिँ क्लाइन्ट्स र अब पेसेन्ट पार्टीलाई चाहिँ त्यो प्रोसिडरको बारेमा डिटेल एक्सप्लेनेसन दिएर इन्फर्म रिटर्न कन्सेन्ट जुन हामीले अहिले गरिरहेको छौँ, तर कसरी गरिरहेको छौँ, ल यसमा सही गर्नुहोस् भने हुन्छ कि तर त्यहाँभित्र के लेखिएको छ, त्यो प्रोसिडर के हो, त्यो प्रोसिडरको एडभान्टेजेस के हो, त्यो प्रोसिडर गरेन भने के हार्म हुन सक्छ भन्ने कुरा हामी क्लियरली एक्सप्लेन गर्दैनौँ र कति कन्टेक्स्टमा चाहिँ त्यो प्रोसिडरको बारेमा हामीले विथ फिगर पनि एक्सप्लेन गर्नुपर्ने हुन्छ। सो द्याट मस्ट बी इन्स्टिट्युटेड टु प्रिभेन्ट द फर्स्ट सिनेरियो, जुन चाहिँ हाम्रो सर्जिकल सेफ्टी एप्लिकेसनको प्री अपरेटिभमा हुने हो भने। अर्को ड्युरिङ अपरेटिभमा पनि हाम्रो क्रिटिकल इभेन्ट्सहरूलाई चाहिँ असेस गर्ने, त्यसमा चाहिँ हाम्रो स्क्रब नर्स, सर्जन र एनेस्थेटिक 3 जनाको रोल हुन्छ भने पोस्ट एनेस्थेसियामा पनि हाम्रो अल्डर स्कोरिङ असेस गरिसकेपछि मात्र उहाँलाई चाहिँ अब के अरे पाकुमा लाने कि अथवा पोस्टअपमा लाने हुनुपर्छ। त्यहाँ चाहिँ मोस्ट इम्पोर्टेन्ट इज द इम्प्लिमेन्टेसन अफ द सर्जिकल सेफ्टी चेकलिस्ट। आई थिङ्क मोस्ट अफ द हस्पिटलमा इम्प्लिमेन्ट भइरहेको छ, तर अनफर्चुनेटली धेरैवटा हस्पिटलमा छैन। यसमा म एउटा दिन्छु, 2.5 इयर्स अगाडि हामी नर्सिङ तथा सोसियल सेक्युरिटी डिभिजन अलिकति जोड्न चाहेँ। अहिले म नाम्समा आबद्ध भए पनि म 4 वर्ष चाहिँ म स्वास्थ्य मन्त्रालय र स्वास्थ्य सेवा विभागमा काम गरेको थिएँ, जुन पोलिसी मेकिङमा पनि भएको भएर हामीले 2.5 वर्ष अगाडि एउटा ठुलो हस्पिटलमा क्लिनिकल अडिट गरेको थियौँ। यसमा 4वटा एरियामा, एउटा सर्जिकल सेफ्टी चेकलिस्टमा, एउटा इन्फेक्सन प्रिभेन्सन एन्ड कन्ट्रोल, अर्को हेल्थ केयर वेस्ट म्यानेजमेन्ट र अर्को चाहिँ क्लाइन्ट सेटिस्फ्याक्सनमा। अनफर्चुनेटली त्यसको के आएको थियो भन्दाखेरि इन्फर्म कन्सेन्ट लिन्छ 58%मा, तर पेसेन्टको एस्पेक्टमा सोद्धाखेरि ओन्ली द 12% नो वाट द प्रोसिडर इज गोइङ अन विथ हिम अर हर एन्ड वाट आर द एडभान्टेज एन्ड वाट आर द रिस्क अकर्ड बाई दिस प्रोसिडर। र अर्को चाहिँ हाम्रो अल्डर स्कोरिङको हेर्दाखेरि उति बेला एनेस्थेसियोलोजिस्टले भन्छ म्याम हाम्रो त आँखा बल्ल खुल्यो, हामीले कहिले पनि त्यो अल्डर स्कोरिङ हेरेर उहाँलाई चाहिँ के अरे ऊबाट रिकभरी युनिटबाट चाहिँ पोस्ट अपरेटिभ र वार्डमा चाहिँ सारेको छैनौँ। यसले त हामीले आफै सेफ्टी गर्ने हुन्छ। एउटा यस सेफ्टीको अस्तिमा मैले भने कि यसलाई क्लाइन्ट सेफ्टीसँग रिलेटेड चाहिँ हाम्रो यो हेल्थ वर्कर सेफ्टी पनि हो। त्यस कारण चाहिँ यो एउटा चाहिँ सर्जिकल सेफ्टी चाहिँ मस्ट नै हो, इन्क्लुडिङ हाम्रो के अरे रिटर्न इन्फर्म्ड कन्सेन्ट।
It is clearly specified in the Drug Act it should be safe first, efficacious, and of the standard quality. Medicine need to be used in the country of origin. This is one of the requirements. So we don't have any procedure for the new drug application. It means that only the medicine which is available in the other part of the country, other part of the world, is only eligible for the registration in Nepal. So there is no any new drug registration procedure here till now. So all the pharmacopoeial medicine are registered based on the specified standard. So medicines are specified in terms of the standard as specified in the different pharmacopoeia. We have recognized different pharmacopoeia, including United States pharmacopoeia, British pharmacopoeia, Indian pharmacopoeia, and other pharmacopoeia also. So for the non-pharmacopoeial and non-standardized new medicine, so it has to be go through the drug evaluation committee of the department, and it is followed to the drug advisory committee, and finally the drug advisory committee recommended for the approval of those type of the medicines. So at the time of the evaluation, we also take the assistance of the physician also at the time when there is requirement, and we also continually communicate with the different society in which the drugs belongs to. And finally, DDA approved the recommendation for the import and the use of the all type of the prescribed medicine based on the prescription. So there is also the provision if there is a prescription for the type of the drug which is not available in the Nepal. So at that time, based on the prescription, we also provide the permission. But here, the management is the sole responsibility of the patient. And there is also the provision of the special permission. So in case where there is any new type of the medicine which is not available in Nepal is required for any institute or for any community or for any type of the prescribers, at that time also we provide the import permission based on the recommendation of the drug and therapeutic committee of that hospital. So here is also a limitation because it is only confined to only that institute. So that is only eligible to dispense or to use in that institute. But those type of the medicine is also required in the other institute also. At that time, that institute also need to take the separate permission for that type of the medicines. It is the sole responsibility of the manufacturer or the importer to ensure the continuous availability of that medicines. So here is, we don't have any provision. So this is the common practice that at least for the 6-month stockpile at the level of the importers or the manufacturers, and at the 3 months of the stock at the institution level. So if we maintain this type of the stock, then definitely there will be no issues of the shortage. Government supply only dedicated towards the limited listed essential medicine only. So there is a limited essential medicine, and now after we are practicing this federalism, so at that time different level of the governments are also procuring the medicine based on their needs. So there is no any central issues or no any central database what type of the medicine has been purchased and where it is being available, where it has been distributed. So those type of information is missing. So because of that, in some institution there is a stockpile, in some institution there is a shortage of the medicine also. The continuous availability of the medicine is very crucial, especially for the critical medicine antidotes. So to ensure that if we can assign any institute, government institute or any other agency like a SAZA or any other institute for the stockpile of those type of the antidotes as well as the medicine, this can be some sort of the instrumental to continuous supply of the medicine also. We are just talking on that also, but this has not been implemented, and it has not been come up with some sort of the solution also.
Drug like tocilizumab. Tocilizumab was widely used. It was coming in guideline in the patients in management of severe COVID patient, but it was given only a one-time fixed drug approval. So we had tocilizumab for 3-4 weeks. Then we did not have tocilizumab for 3-4 weeks. Then again we had tocilizumab for 3-4 weeks. But we had all the COVID patients for all the year long. So what do we do in that gap where we do not have tocilizumab and it was only one-time use, one-time approval? So we had to resort to alternative medicines like maybe bevacizumab, which were not effective. So yes, the patients were suffering. Again, I come to COVID. So there was again this thing about mucormycosis. It was there. We are in tertiary center. So there are a couple of mucormycosis cases. They were referred for us for management of mucormycosis. So did we have liposomal amphotericin B? The answer is no. So what do we do then? We have mucormycosis, but we don't have liposomal amphotericin B. Then we have to resort to amphotericin deoxycholate, which is more toxic. Patient may have more renal impairment, but we do not have choice. So are patients suffering? Yes. And we even did not have amphotericin B, and we had to revert to other antifungals like posaconazole. So we have to go multiple times beyond guidelines. We have to compromise patient safety, and every time the sufferer is the patient. This is just for the COVID. Other examples also I'd like to give, like maybe other thing, like methyl dopa, a very simple drug that is used in PIH. Is it available? Are the patients suffering from PIH only in Baisakh, Jet, Asar? They don't suffer from PIH in Fagun. So we don't have regular methyl dopa supply. Another drug is labetalol. Like we have neuro patients, we have to control their blood pressure. Labetalol is not available. It's occasionally available. And we have to use other antiparentals to cover the blood pressure. Although we know that they might have lesser side effect profile, they might increase ICP, but we have no choice. So we compromise the safety. Other drug is like anti-seizure medications, which are not regularly available. So we have to treat patients who are in seizure with the anti-seizure drugs that have lesser safety profile. Although we know that we have better medications that have got better safety profile.
नेपालको फार्मास्युटिकल अवस्था हेऱ्यो भने हामी विश्वको फार्मास्युटिकल भन्दा अराउन्ड 300 पछाडि छौँ. 300 वर्ष पछाडि हो मेरो एनालिसिसमा. यहाँ नजिकै हाम्रा छिमेकी मुलुकहरू बङ्गलादेश, इन्डिया, पाकिस्तान, यिनीहरूभन्दा हामी केही नभए 1 दशकभन्दा बढी पछाडि छौँ. र पनि एउटा सराहनीय काम नेपाल औषधिको रहेको देखिन्छ. 1972 सालमा 1972 इस्वी सम्बत भयो. नेपाली प्राइभेट सेक्टरबाट कुनै पनि संस्थाले पारासिटामोलको अनएक्सपेक्टेड रेट बढेको बेलामा नेपाल औषधिले बाहेक धेरै लिमिटेड संस्थाहरू छन् जसले सिटामोल दिन सक्षम भएका छन्. तर नेपाल औषधि आफ्नो दायित्वमा रहेर आफ्नो क्षमताअनुसार औषधिहरू दिएका छन्. अब आगामी दिनहरूमा हाम्रा योजनाहरू छ. क्रमबद्धमा हामी यसलाई एक्लै नेपाल औषधिले पक्कै पनि धान्न सक्ने अवस्था छैन, अगाडि जान सक्ने अवस्था छैन. तर अहिलेको अवस्थामा उद्योग मन्त्रालय, स्वास्थ्य मन्त्रालय, औषधि व्यवस्था विभाग र हाम्रा विज्ञहरू जति छन् सबैको पूर्ण सहयोग पाइएको छ. र संस्था आफ्नो प्लानिङ योजनालाई पुनः कमसेकम केही नभए 141 वटा इसेन्सियल मेडिसिन सहितका जुन उत्पादन छन् यसलाई हामीले 2 वर्षभित्रमा पुरा गरी स्मल र लार्ज भोल्युम प्यारेन्टल सहितको एउटा खाका हामीले सरकार समक्ष पेश गरेका छौँ। यदि त्यो हुन्छ भने मलाई लाग्छ इसेन्सियल मेडिसिनको समस्यालाई हामीले सम्बोधन गर्न सक्ने अवस्था चाहिँ छ।
If we can do sourcing based on what we need, what is the shortage, we identify essential drug, we identify life-saving drugs and all those things, but then we do not do the mapping. We need to do mapping. We need to see what is available in the market, what we are manufacturing, and what we are not manufacturing, and globally we can look at who are producing or who are the suppliers. So sometimes, because of our small volume, scale, so sometimes we may not get what we are looking for, but then the regulators can keep on a balance. So whenever the applicants come for the registration or come for the application for the evaluation and registration, so they can depending on the manufacturer's activity, what they are producing, they can explore. What about this one? So sometimes some of the things that I did at that time is one of the Nepalese company, so who was basically limited on oral and the external things. So we persuaded him to come to injectables, and they did injectables, including narcotic things. So that way there was an acute shortage of the narcotics. So that way we were able to address this thing. So sourcing, by doing sourcing, we can eliminate dumping. So by eliminating dumping, so we can ensure patient safety in a way, means that so far as health product is concerned. So
the competency to evaluate the dossier, this might be the part of the registration requirement, registration department has to look. And whether the competency to actually study the safety, of monitor the product safety issues in the market, like in academia, in hospitals, whether we have a suitable, competent people working in that area or not. That also plays a big role. And third thing is definitely registration regulation and evaluation competency, as I mentioned. This part also causing some sort of safety issues. And another thing is surveillance. I think some of the part is covered now. Safety surveillance is very weak. I think Balkrishnan sir also mentioned, we have to have a concerted effort to surveil, the safety issues of the product. Whether we are linked, we have a very, I would say that it's like a primitive type of connection between the regulatory and hospitals or clinicians or academia. There is not any environment we have been able to really create. This is also a big hurdle for us. We have a PB program. We have some regional PB centers. But what is the situation of reporting? As Santoshi was mentioning, we have a pathway to allow medicines on the basis of recommendation of clinicians, but whether they are reporting back about the output of what you call that, result of the patient, drug, whether it is really treating or causing more problem. It is not actually linked. So surveillance system is not in really good form now. That is also a big barrier. If we look into the further, if you go dig down into that, we mentioned before, in order to avail quality medicine, that's okay. But if there is no economy of scale, who is going to really supply? The supplier is not interested. Manufacturer is not interested. So they will leave. Then government has to take the charge. In that case, I am more concerned whether the government should take lead of those shortage medicine, critical care medicine. I think I would say yes, government has to have, or certain organizations should be in place within the ministry, so that that organization looks after these shortage type of only medicines. All other medicines where there is a economy of scale available, everybody can manufacture and supply, and that they will be available very much easily. But in those type of products, it's very difficult for them, and we are not been able to really address that. Maybe we can make compulsory to manufacture certain products, as Balkrishnan sir says, okay, we are doing that currently. But one batch of phenobarbital injection will be okay for a whole year, And some of the clinicians would complain, this this is not working well. I need the other one, other brand. So these are the choices differences also. So really, there are intricacies inside. We have to look into that also. So there are hurdles or barriers because of economy of scale. And as I mentioned that, we have to focus on what you call a good collaborative environment, collaborative systems. So we are I'm requesting all stakeholders, please give us your experts, interest to be part of the regulation. I'm mentioning that once again because we have been openly announcing anyone expert in this area to select a certain type of new medicines. If they are really needed, they can come to us, they can sit with us, we can discuss on that, we can allow them. We have a pathway for that also.
The next concourse is on the topic patient safety improvements in everyday practice. Healthcare professionals can help improve patient safety through patient-centered care strategies and incorporating the patient as a part of the care team. Properly engaging patients, driving patient satisfaction, and listening to patients are critical to supporting patient safety initiatives. Moving on, for the moderation of this session on this topic, I would like to call upon the stage Professor Dr. Subhash Prasad Acharya. Dr. Subhash Prasad Acharya is professor at IOM TUTH and president of Nepal Critical Care Development Foundation, working as visitor consultant, intensivist, and head of ICU and infection prevention control at Grande International Hospital, Nepal. Thank you.
Thank you. You see, I have many nurses in this panel, so which will also help to show that we are empowering our nurses.
We have implemented the protocol from Nepalese Society of Critical Care Medicine, and I would like to remember the speech from Professor Dr. Bhagwan Koirala that he said, unless we give authority to the nurses, the patient safety won't be improved in any hospital, in any healthcare setting. So I believe that these protocols helps to provide some kind of authority and within a boundary. Hence, nurses are able to implement the things in emergency condition and able to improvise the patient safety in somehow.
If you only try to do things by external motivation, like following the rules or procedures or protocols, like you can think that I should follow the rules because I have to. You should move from there. You should move from there and try to build teams where you should get the motivation from inside yourself and from the team within, where you should do things because you want to. You should be the advocate for that thing. So when you do that, when you have that internal motivation and commitment for leadership, role modeling, engagement, and influencing others, then no harm is usually a choice. There is usually no harm to the patient in that situation. So we should always try to move from being reactive, from acting from natural instinct, to work as a team, where everything is incorporated. There is check and balance. If one person does wrong, then someone else balances that. So how to get there from acting from natural instinct to work as a team? So you should have some concrete strategies. The first and the small or a big thing that you should incorporate is having a system of identifying the problems. And checklists, like we have also talked about it many times before, these checklists are very important. You can have many checklists in your ICU or in your hospital. And different studies have found that only by using checklists, there are significant reduction in mortality, significant reduction in major complications, significant reduction in length of stay in the hospital, and significant reduction in communication failures. Other important thing is when you identify problems, you should resolve it through teaching, like team training, having workshop, bedside teaching sessions, or problem-based learning rounds and communication sessions, or even starting fellowship programs. This also decreases a lot of complications in ICU. Executive ward rounds are another important thing. This executive ward round means that you should invite your administrative personnel to your ICU and show them what's being done and what needs to be done. This increases the perception of the problem and helps to develop culture. if you want to build culture in an ICU, this CUSP model, CUSP is Comprehensive Unit-Based Safety Program designed by Agency for Healthcare Research and Quality. This is somewhat where you team up your team members, bring together all the clinical evidences, and bring up the science of safety together so that you can build your culture locally in your unit, so that there is better safety evidences or better safety incidences in your ICU. So I would like to end my presentation with this small example. This is a tale of two organizations. Mr. X got admitted in ICU. Someone ordered chemical DVT prophylaxis, but he missed that during ICU stay. When he got transferred in the ward, he developed pulmonary embolism and he died. There is one organization where there is no patient safety culture. The patient safety department is there who was informed. Root cause analysis was also done. But the nurses, what they did was the nurses involved in the care were called and they were warned not to repeat the same mistake. So there is another organization who practices safety culture. So what they did was patient safety department was informed. Root cause analysis was also done. What they did was they made action plans so that the error doesn't repeat again. They made a new mechanism or the new cardiac system for better medication orders. Better communication tools were designed so that they can communicate with the pharmacy in a better way. They retrained the nurses, and they also planned for a 6-month follow-up to see if this worked or not. So you can decide which organization you want to be with. Thank you.
Thank you, Dr. Saben. Thank you for a wonderful talk about safety culture. As in your talk, you mentioned about various checklists, and I have a question. So, who do you think shall be doing those checklists and those extra documentations? If we talk about nurses, being in a public hospital, the nurses are already overburdened. Like we never have adequate nurse-patient ratio. अब आइसियूमा म्यानेजमेन्टलाई हस्पिटललाई चाहिँ हामीलाई 1:1, 1:2 चाहिन्छ भने के हुन्छ म्यानेजमेन्टको एन्सर भन्यो भने डाक्टर साहब यो त अमेरिका होइन, यहाँ त 1:3, 1:4 ले चलाउनुपर्छ आइसियू भन्ने एन्सर आउँछ होइन. तर by adding all these processes like checklist or other things, don't you feel that we are more overburdening the nurses and taking their reducing their clinical time and then using them for documentations and other processes? What do you feel about it?
Well, that's a very important question. Thank you. So whenever we think about patient management, we should also always think in two ways. One, the patient comes with some problem and we address that problem. But our objective should also be not to add added problem to the patient. That's very important. Most of the hospitals or most of the institutions think that if someone comes with a problem, the main idea of treatment is just to treat what the problem is. And we accept, if someone develops DVT, we accept that. If someone develops hospital-acquired infection, then we easily accept that. But we shouldn't do that. If we want to give optimal care, then if we want to develop this culture of patient safety, then we should always do things with standard. And nothing comes for free. If you want to do something good, you have to pay for it. Like someone has to pay for it. There comes extra cost for it. But we shouldn't compromise with safety. If 1:1 nursing is needed for that patient, we should go for it. We should always ask for 1:1 nursing if that's needed. But for checklists are also important in the same time. So if the nurses are getting extra burdened with the checklist, then we can think of how we can reduce that burden. I can give you one example. Like in ICU, we need to feed our patients. If you see the time of the nurses spending their time in feeding their patient, it's like around 10 to 20% of the time they just spend at the patient side holding the syringe, feeding the patient. If you can only give a syringe like a feeding pump for one patient, then we can reduce that time and utilize that time in something very important and good things. I think we should invest, we should ask for more budget, we should ask for more nurses, and think in a way how we can reduce the unnecessary time our nurses are spending on patient care. Thank you.
Great, thank you. Thank you, Dr. Sabit. Now I'd like to call upon our next speaker. He's the last speaker for the session, Dr. Diptesh Saryal.
Namaste सबैजनालाई. So I'll be using both English and Nepali during my presentation. So for next few minutes, what I'd like to share with you all is, like, since this early morning, we have been repeatedly hearing that we need to do this, we need to do that, if you want to improve the patient safety. But when you talk about building a system, and I'm going to talk about a health system, so it's called a learning health system. So if you want to run an organization, or you want to provide the clinical services, or you want to manage the operations, so there's a system within the healthcare, and it is learning health system. So, but before that, I'd like to start with this question: how safe are our ICUs? अहिले नेपालमा suppose 200 odd ICUs होलान्, हैन? मैले चाहिँ लेभल 3 ICU कुरा गरेको. त्यसमा कुन चाहिँ ICUहरु चाहिँ सेफ होलान्, कुन ICUहरुमा चाहिँ उनीहरुको परफर्मेन्स चाहिँ अप्टिमम नहोला, अथवा कुन ICU चाहिँ लाइक हैन यो त अति नै भइसक्यो, यो त बन्दै गर्नुपर्ने बेला भइसक्यो भनेको के थाहा छ तपाईहरुलाई? मलाई पनि थाहा छैन. We don't know anything whether our ICUs are safe or not, and same applies to the hospitals. Since I'm an intensivist, I just want to focus on ICUs, but same applies to the hospitals. We don't know how safe are our hospitals. के गर्ने त हो त्यसो भए? We need to build our health system. We need to de-learn some of the things, relearn some of the things, and try to make some progress there. So this is what the learning health system does. A learning health system is a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge captured as an integral byproduct of the delivery experience. भन्न खोजेको चाहिँ त्यो सर्भिस प्रोवाइड गर्दाखेरि अब यो साइन्स, इन्फर्मेटिक्स, इन्सेन्टिभ्स, कल्चर त एसेन्स भयो हैन. हुनु पर्यो चाहिँ के भन्दाखेरि हामीले कन्टिन्युअसली काम गर्दै जाने, लर्न गर्दै जाने, काम गर्ने, लर्न गर्ने, अनि फेरि त्यसैमा इम्प्रुभमेन्ट चाहिन्छ नि, इम्प्रुभमेन्ट गर्ने, अथवा त्यही लाइक हामीले एउटा टार्गेट मिट गरेको छ भने त्यही कन्टिन्यू गर्ने हैन, सस्टेन गर्ने भन्ने कुरा नै लर्निङ हेल्थ सिस्टम हो के. यसमा तर तीनटा कम्पोनेन्ट हुन्छ. एउटा हुन्छ नलेज, हामीले धेरै नलेज सेयर गरिसक्यौँ आज हैन. बिहानदेखि यो गर्नुपर्छ, त्यो गर्नुपर्छ, यस्तो बनाछौँ, प्रोटोकल बनाछौँ, भ्याप बन्डल बनाएका छौँ, भ्याप बन्डलको चेकलिस्ट बनाएका छौँ, भ्याप बन्डल इम्प्लिमेन्ट गरेका छौँ हैन, आइसियु प्रोटोकल बनाछौँ. भनेपछि नलेज भयो. त्यसलाई हामीले प्र्याक्टिसमा पनि लिएर गयौँ, ट्रान्सलेसन पनि भयो कति ठाउँमा. अब कति ठाउँमा हुँदैछ यो बिस्तारै, अब यस्तै यस्तै फोरमहरूले चाहिँ यसलाई अगाडि लिएर जान्छन् हैन. तर अर्को एउटा इम्पोर्टेन्ट कम्पोनेन्ट हुन्छ क्या लर्निङ हेल्थ सिस्टमको, त्यो भनेको चाहिँ डेटा. आर वी मेजरिङ आवर पर्फर्मेन्स? तपाईँले जस्तै मेरै छोरीको पर्फर्मेन्स के छ भन्ने कुरा मैले उसको रिपोर्ट कार्ड नहेरिकन कसरी थाहा पाउने? मैले उसलाई चाहिँ केमा फोकस गर्नुपर्छ, कुन क्लासलाई चाहिँ अलिकति प्रायोरिटाइज गर्नुपर्छ, कुनमा पुगिरहेको छैन भन्ने कुरा कसरी थाहा हुन्छ हैन? ल यसो पढ्नुपर्छ, होमवर्क गर्नुपर्छ भनेर मात्रै त भएन, के भइरहेछ भन्ने कुरा त एनालाइज गर्नुपर्छ. सेम अप्लाइज टु द हेल्थ सिस्टम. सो दिस इज वाट अ लर्निङ हेल्थ सिस्टम इज अल अबाउट. एन्ड देयर आर सिम्पली one objective of learning health system: to learn as quickly as possible about the best medical care for each person and to deliver it. त्यसको लागि के चाहियो भन्दाखेरि this requires support of complete learning cycle. लर्निङ साइकलको बारेमा म भनिरहदिनँ, त्यसको एउटा साइकल तपाईहरुलाई थाहा छ. पढाउने हैन, पर्फर्मेन्स इभ्यालुएट गर्ने, इम्प्रुभमेन्ट गर्ने, त्यो साइकल हुन्छ. But this also requires a scalable infrastructure or a platform. I know, without a platform, we are lost. हामी कहीँ पुग्दैनौँ. कसरी गर्ने त? ल पढाउनलाई त हामीले टिचिङ इन्स्टिट्युटहरू डेभलप गऱ्यौँ हैन, मेडिकल कलेज गरेछ, नर्सिङ कलेज भनेछ, वर्कसप गरिन्छ हैन, अनि प्र्याक्टिस पनि भइरहेछ हैन, प्र्याक्टिसनर्सहरूले गरिरहनु भएको छ. तर मेजर गर्नलाई के छ त? जस्तै मैले अघि बिहान पनि क्वेसन सोधेँ, अब मेडिकल एरर रिपोर्ट गर्नलाई मसँग के टुल छ हैन? मेडिकेसन एरर त्यो जुन अब इम्प्रुभ गर्नुपर्छ भन्ने कुरा भयो नि, कसरी थाहा हुन्छ हैन? कसरी त्यो क्याप्चर गर्ने, के कसरी मेजर गर्ने त प्रब्लम के हो भन्ने कुरा हैन? त्यसको लागि चाहिँ आई एम गोइङ टु टेक एन इक्जाम्पल अफ आइसियु रेजिस्ट्री. आइसियु रेजिस्ट्री चाहिँ अब हामीले सबै कुराहरू धेरै वर्षसम्म अब नलेज प्र्याक्टिसमा धेरै फोकस गऱ्यौँ, तर खासै धेरै उपलब्धि भएनन्. हुन चाहिँ भए हैन, तर जति हुनु पर्थ्यो नि त्यति चाहिँ भएन कि. किन भएन भनेर हेर्दाखेरि चाहिँ हामी कहाँ ल्याग गरिरहेछौँ भन्दाखेरि वी डोन्ट नो वेयर वी स्ट्यान्ड. टिचिङ हस्पिटलको आइसियु र XYZ आइसियुमा के फरक छ? वाइ someone would like to go to ICU of teaching hospital and not any other hospital? के फरक छ टिचिङ हस्पिटलको आइसियुमा हैन? फर इक्जाम्पल ह्याम्सको आइसियुमा के फरक छ? म ऱ्यान्डमली लिएको आफ्नै कलिगहरूको हस्पिटल हुनाले हैन, अर्को नै त्यस्तो हैन. र XYZ हस्पिटल चाहिँ के फरक छ त? वी डोन्ट नो. त्यसैले अब रेजिस्ट्रीले चाहिँ हामीले के गरिरहेछौँ भन्दाखेरि वी आर ट्राइङ टु बिल्ड रेजिस्ट्री एज इन्टिग्रल पार्ट अफ द लर्निङ हेल्थ सिस्टम, जहाँ चाहिँ वी आर कन्टिन्युसली इभ्यालुएट आवर पर्फर्मेन्स बेस्ड अन डेटा, बेस्ड अन एभिडेन्स हैन. वी क्याप्चर रियल वर्ल्ड डेली लाइक देयर आर भेरिएबल्स हैन. जस्तै हाम्रो आइसियुमा कुन एजका बिरामी धेरै आउँछन्, हाम्रो आइसियुमा कुन डायग्नोसिस भएको बिरामी सबभन्दा कमन आउँदो रहेछन्, उनीहरूको एभरेज लेन्थ अफ स्टे कति हुँदो रहेछ, कतिजना बिरामी चाहिँ भेन्टिलेटरमा जाँदो रहेछन्, कतिजनाको चाहिँ मोर्टालिटी हुँदो रहेछ, कतिजना सर्भाइभ गर्दो रहेछन्, कतिजना रिएडमिसन हुँदो रहेछन् भन्ने कुरा चाहिँ हामी मेजर गर्दैछौँ. र यो चाहिँ हामीले अहिले 15वटा आइसियुमा इम्प्लिमेन्ट गरिरहेछौँ. एन्ड दे आर लुकिङ एट देयर पर्फर्मेन्स. अब उनीहरूसँग छ, आफ्नो रिपोर्ट कार्ड आफ्नो हातमा छ. नाउ इट्स अप टु देम वेदर दे वान्ट टु इम्प्रुभ अन इट अर नट हैन. भनेपछि यो कुरालाई चाहिँ हामीले इन्टिग्रेट गरिरहेछौँ. अब यो फिगरमा चाहिँ मैले के देखाउन खोजेँ भन्दाखेरि अहिले जस्तै मैले भने नि, हामीले नाउ वी आर ट्राइङ टु एसेम्बल द डेटा, एसेम्बल द पर्फर्मेन्स मार्कर्स, मेट्रिक्सहरू एसेम्बल गर्दैछौँ. त्यसलाई एनालाइज पनि गरिरहेछौँ. एनालाइज गरेर इन्टरप्रेट गरेर रिजल्ट्स पनि निकालिरहेछौँ. तर हामी यो नगरेर कुनै पनि यो प्रोसेसको चाहिँ के हुन्थ्यो त? अब त्यो जुन रिजल्ट आयो नि, रिजल्टलाई वी हेभ टु टेक इट ब्याक टु द कन्टेक्स्ट. त्यही ठाउँमा लगेर हामीले कुनै इन्टरभेन्सन डिजाइन गरेर इम्प्लिमेन्ट गरेर फेरि त्यो साइकल कन्टिन्यू गर्नुपर्ने हो नि हैन. तर यस्तो हुँदैन. तपाईँहरू नेपालबाट पब्लिस भएको रिसर्च पेपरहरू हेर्नु एकचोटि, के भइरहेछ भन्दाखेरि हुन चाहिँ यस्तो भइरहेछ कि हामी डेटा कलेक्ट गरिरहेछौँ, एनालाइज पनि गरिरहेछौँ, रिजल्ट पनि लेखिरहेछौँ, म्यानुस्क्रिप्ट पनि तयार गरिरहेछ, प्रब्लम पनि आइडेन्टिफाई गरिरहेछ. तर फोकस कहाँ छ? खालि पब्लिकेसनमा. गइ कहाँ रहेछ? यो नराम्रो होइन, जर्नलमा निस्किनुपर्छ, इट इज पार्ट अफ द प्रोसेस. तर जुन यो अघिको जुन साइकल कम्प्लिट हुनुपर्थ्यो नि, त्यो भइरहेको छैन. इट्स नट गोइङ ब्याक टु द साइट्स. जस्तै तपाईँहरूले अहिले आइसियुमै अहिले जस्तै आई एम पार्ट अफ वान क्लिनिकल ट्रायल हैन, एउटा चाहिँ कोभिडमा वी आर डुइङ अ क्लिनिकल ट्रायल. अहिलेको हाम्रो कोभिडको प्र्याक्टिस इज बेस्ड अन द फाइन्डिङ्स फ्रम द डेभलप्ड कन्ट्रिज. युकेमा स्टेरोइडले काम गर्यो, हामी स्टेरोइड सुरु गऱ्यौँ. युकेमा यो औषधिले काम गर्यो, फाइजरको यो औषधिले काम गर्यो, यहाँ पनि गर्छौँ. हाम्रोमा टेस्ट गर्ने कि नगर्ने, आफ्नो कन्टेक्स्ट अनुसार डेभलप गर्ने कि नगर्ने, र आफ्नैमा गर्न पायो भने त त्यसको भ्यालिडिटी बढ्यो नि त हैन. अहिले हामीले हाम्रो एन्टिकोअगुलेसनको कोभिडमा चाहिँ ट्रायल गर्दैछौँ. एन्ड इट हेज सोन द्याट सर्टेन काइन्ड अफ डोजिङ चेन्जेस इन एन्टिकोअगुलेसन डज हेल्प सम काइन्ड अफ कोभिड पेसेन्ट्स. हाम्रो आफ्नो पपुलेसन. एन्ड नाउ वी आर, त्यो पब्लिस पनि भयो, न्यू इङ्ल्यान्ड जर्नलमा पब्लिस पनि भयो. एन्ड वी चेन्ज आवर प्र्याक्टिस टु डु आवर आइसियुज हैन. त्यो किन त्यो हामीले गरेको थियौँ नि त. भने चाहिँ त्यो किसिमले चाहिँ एउटा लर्निङ हेल्थ सिस्टम चाहिँ डेभलप गर्ने ट्राई गरिरहेछौँ र एभिडेन्स बेस्ड प्र्याक्टिस चाहिँ डेभलप गर्ने ट्राई गरिरहेछौँ. अब क्वालिटी अफ केयरको बारेमा धेरै भट्टाइर दिन होइन यसले चाहिँ अब खालि क्वालिटी भनेको चाहिँ लग्जरी होइन कि इट्स अ निड भइसक्यो ब्याड क्वालिटी सर्भिसेस गिभ्स अस पोरर आउटकम्स मच मोर वर्स देन जुन डेलिभरी अफ यो क्लिनिकल सर्भिसेस हुन्छ नि इफ दे आर अफ पोर क्वालिटी त्यो उपचार नपाउनुभन्दा झन् पोर क्वालिटी उपचार पाएर चाहिँ झन् आउटकम वर्स भएको भन्ने कुरा प्रुभ भइसक्यो कि यो ल्यान्डसेटमै ग्लोबल हेल्थमा पब्लिस भइसकेको छ यो सबैले एक्सेप्ट गरिसकेका छन् यो कुरा अब यसमा चाहिँ हामी धेरै डिस्कस नगरौँ त्यसैले अब हामीले चाहिँ आइसीमा के गऱ्यौँ भन्दाखेरि वी निड समथिङ टु मेजर आवर पर्फर्मेन्स भनेर चाहिँ वी स्टार्टेड implemented the ICU registry. Now what we are trying to do is, we don't have enough data on outcome measures and we need to capture outcome measures because they are important in benchmarking. अहिले जुन मैले भनेको थिएँ नि हामी कहाँ छौँ त हाम्रो हैसियत के छ अझै ग्लोबल सिनेरियोमा कहाँ छौँ हामी भन्ने कुरा हामीलाई थाहा छैन त्यो क्याप्चर गर्नलाई पनि हामीसँग सर्भाइभल मेजर्सहरूको डेटा चाहिन्छ इभेन्ट्स अफ इन्ट्रेस्ट अहिले जुन उसले एउटा इभेन्ट डिस्क्राइब गर्यो स्वाप मेडिसिन स्वाप हुन सक्थ्यो द्याट्स एन इभेन्ट अफ इन्ट्रेस्ट त्यो मेजर गरियो नि त मेजर गरेर बल्ल करेक्ट गर्न सकियो रिसोर्स युटिलाइजेसन आर यु युजिङ आवर रिसोर्सेस अप्रोप्रिएटली भन्ने कुराहरू होइन कस्ट अफ केयर